Okay, hello, my name is Bridget Blansfield. This patient case was chosen as my SOAP this week because the patient was extremely resistant initially to lifestyle changes to benefit her health and well being. It was a great educational moment as a student because I anticipate seeing many patients like this in my future practice. Understanding existing barriers, educational gaps, and implementing cultural competence will be important to empowering and effectively treating patients with chronic diseases in primary care. So, this is why I chose this. PN, let's get it started. So, PN uh, was born 8/6/73. She is a 50-year-old Hispanic female who presents with her daughter and is an established patient at Family Practice Specialist in Phoenix, Arizona. She is a reliable historian and she states, I'm here because I'm feeling numbness and tingling in my hands and feet. So PN presents to the clinic for intermittent numbness and tingling in her hands and feet that have lasted from a few seconds to minutes at a time. Her symptoms are getting progressively worse for the past 6 months and now is affecting her work. She states that she has not been taking anything over the counter to relieve the pain. She denies any recent traumas, illness, fever, chills, or changes to her medication. So PN was last seen in the office for her physical exam in January of 23, where she was notified of an increase in her A1C and prompted to follow up, but there was no response. So she's here today, 4 or 5 months later. The patient was or has a history of asthma, insomnia, obesity, hypertension, diabetes type 2. She is on chlorthalidone, trazodone for sleep, montelukast for her allergies, albuterol for asthma, metformin 500 milligrams BID, and simvastatin 10 milligrams daily. She does not have any known drug allergies or to food or to environment. Family history is unknown because PN was adopted and she does have two living children and she is married to her husband for the past 15 years. Her past surgical history is a abenectomy and a hemorrhoidectomy in 2019. She has not seen an ophthalmologist for her annual eye exam or a podiatrist for a diabetic foot exam. For either of those, she's never seen anyone. So today, she also says that she is up to date on all our immunizations. Her last mammogram was in 23, and this is in January. Completed the Cologuard a year ago. Her last PAP was in 2022 with all normal results. Patient denies any alcohol, smoking, or illicit drugs. She is a receptionist at a dental office for the past 5 years. She does not exercise and reports a sedentary lifestyle and a poor diet of fast food and processed food. Review assistance for PN for constitutional. She is well nourished. She is in no acute distress. Denies any fever or weight changes, denies headache, she denies any changes to her vision or blurry vision. Cardiac, she denies any dyspnea at rest or exertion. She denies any palpitations or shortness of breath. She denies any wheezing, coughing, rapid respirations. She denies any diarrhea, constipation, vomiting, or blood in her stool. She denies any urinary frequency, burning, pain on urination. Denies any joint stiffness, muscle weakness, or limited range of motion. She does report intermittent tingling and numbness in her hands and feet. For endocrine, she does report fatigue, denies any changes to her appetite or sweating at night, and then she does report sleep disturbances, which is not a new thing for her. So, upon physical examination today, her vitals are normal except for a slightly elevated blood pressure of 130/70, and her BMI is 35.4, which qualifies her as obese. So, pertinent recent histories include that A1C of 7.9. She has a normal lipid panel, and her fasting blood glucose was 133, and this is back in January. Upon physical examination, everything else is unremarkable. Bilateral upper and lower extremities, she has 2+ peripheral pulses. She's warm to touch. Her cap refills are less than 3 seconds. And she does have visual hair growth on her fingers and her toes. So differentials to consider for PN are diabetic peripheral neuropathy, vitamin B12, and peripheral artery disease. The first differential is vitamin B12 deficiency, and this is based on the patient presenting with symmetric numbness and paresthesia in bilateral extremities. These findings are consistent with vitamin B12 deficiency and typically present first distally and then progress proximally uh, asymmetric in nature and may eventually cause gait and neurological disturbances. However, this is less likely because she is not vegan, she is not at an advanced age, she's not using any PPIs, and she's never had any gastric bypass surgery, which are all reasons that can decrease the absorption of B12 in the GI tract. The second differential in this case is peripheral arterial disease, which is most commonly cause of atherosclerosis, and presentation depends on the severity of the disease. It can present with intermittent claudication from inadequate blood flow to the lower extremities, which is relieved with rest. Her symptoms for PAD include her risk factors for PAD include diabetes, hypertension, low levels of exercise, and being over 40. However, this is less likely the differential because her symptoms aren't associated with exercise. She has good distal pulses, and her upper extremities aren't typically associated with PAD, which in this case, she has symptoms in her upper extremities as well. My leading differential for this case study is diabetic peripheral neuropathy, as is a common complication of diabetes and is most likely due to her uncontrolled blood pressure. Diabetic peripheral neuropathy is a peripheral nerve dysfunction that can be asymptomatic in nature for individuals or can cause pain, loss of peripheral sensation, weakness, and tingling. PN does not practice healthy eating. She is sedentary and she has hypertension, obesity, which are all contributing factors that can worsen the blood glucose levels and further progress that microvascular complications that can occur in the body. So, plan for PN. The diagnosis recommended for her today will be more labs to monitor the progression of her diabetes since the last one was over 3 months ago. She will have a fasting blood glucose, an A1C, a serum vitamin B12, a CBC, a urine albumin creatinine ratio, and a CMP to identify any renal dysfunction, also liver function test to evaluate for hepatic disease, and ESR rate to evaluate for any inflammatory markers. PN will also have an ankle brachial test performed, and then this was actually normal on exam, so PAD was ruled out. The patient's medications will also be reviewed and make sure she's still taking that metformin at 500 milligrams BID, if she's compliant with this. If she is, I do want to add another diabetic medication called Ozempic. This is a GLP-1 receptor agonist and it's indicated for glycemic control, which she definitely needs, reduces the risk of cardiovascular events, which she is high risk for, and weight loss, which she is obese. She is on board for the injectable Ozempic and will be initiated at 0.25 milligrams injected weekly for the first month, and then she will be slowly titrated up. She'll also be asked to check her AM fasting glucose levels and to bring a journal in of her values at her next visit. I also want to start her on gabapentin 100 milligrams once daily and see if this is helping improve her neuropathy symptoms. Treatment will also consist of major lifestyle modifications, including incorporating a healthy diet of low-fat, low-carb, low-salt diet. She will be referred to a registered dietitian nutritionist who can spend some time with her and really teach her the importance of her diet affecting her diabetes, her blood pressure, and her weight. According to the American Heart Association, she is advised to do at least 150 minutes of moderate exercise a week or 75 minutes of high intensity cardiovascular exercise. We will spend some time diving into what she likes to do to get her moving. Some suggestions might be a dance class or walking in the park. She also will be educated and referred to see annually a ophthalmologist and a diabetic podiatrist. The patient is advised to follow up in 1 month. I do at this time want to review her AM fasting glucose levels, review her blood pressure, see how she's tolerating the Ozempic, and see if she saw the dietitian. I'm hoping by advocating the importance of positive lifestyle changes, she will slowly start implementing these to start into her daily practice. According to the American Diabetes Association, there is no perfect percentage of calories from carbs, protein, and fat, and diets are individualized to one's specific needs. Losing modest amounts of weight can improve blood glucose levels and improve health outcomes. The registered dietitian nutritionist will be very beneficial in assessing her specific caloric needs. Obviously, this patient has a lot of risk factors contributing to her diabetes, and decreasing that blood glucose level will hopefully reduce other, potential complications like her neuropathy. Through this process, it's also important to educate her on all the resources that are available to her because she does have a lot. So initially, I was told this patient was guarded and resistant in making changes to her health. Prior to the appointment, my preceptor invited a family member to come with PN to the appointment. He advised her over the phone this would be a great way to involve her family to help her make some positive changes. So her daughter came to the appointment. Um, Her daughter was on board with the plan, which in turn made PN more accepting and more, likely making those changes to her health. I thought this was a great idea because family is very important and can positively or negatively impact our lives. The patient was at first very resistant. Her arms were crushed. She just didn't want anything to do with the change. So throughout the whole visit, her body language dramatically changed by the end of the visit. My preceptor demonstrated Jean Watson's caring science with inclusiveness by incorporating a family member to be a part of her journey towards health. I also found this visit to be extremely engaging as a genuine teaching learning experience by my preceptor for the patient as well as for me as a student. I also found this visit was approached with authentic presence by myself and by my preceptor, which allowed PN to completely engage and trust us in the next steps of her health. So I felt this was a very successful visit, and I'm very curious to see how PN, progresses in the future with her A1C and kind of making improvements to her health. All right, thank you.